we will start. Okay, so welcome all of you to yet another session of our One Health Knowledge Cafe webinar. Today we are going to talk about implications of COVID-19 to society, ecology, and the environment. And we have Sabine, I think you need to help. I cannot move the screen. Sabine, are you there, please? Okay, good. So the One Health Knowledge Cafe is a collaborative effort of more than 11 individuals representing CIH, that's the Center for International Health Partners and Alumni. And we are from Asia, Africa, Europe, South America, and North America. And the whole idea is to bring together the expertise and network of researchers and professionals from various disciplines, countries, and expertise to enable cross-learning, sharing, and network building. And so over the past close to a year now, we have been having monthly talks, webinars, online courses, and discussions. And this has all been made possible by LMU, Center for International Health, through the DAD Exceed program funded by DMZ. And so just a few housekeeping rules. Kindly keep yourself muted unless you are speaking. Keep your video off if you are not presenting. And this session will be recorded and shared. So please bear with us. Also, the PowerPoint slides will be shared in the CIH website. We'll have Q&A session at the end of it all. And any specific questions to a particular presenter, just for clarification, is limited to 2 minutes per 2 questions, just because we want to give everybody an opportunity to be able to ask a question. And so the presentations in all will be 15 minutes per presenter, and we are hoping we'll have enough time of about 30 minutes for the Q&A. So our presenters, our speakers for today are Professor Christian Munte and Dr. Katharina Kreppel. So Professor Munte is a professor of practical philosophy, and he conducts research and policy issues in the intersection of health, science, and technology, and the environment. And he collaborates with researchers and practitioners from different areas, so medicine and care, the environment, natural and technological science, economics, law, and politics. And he's frequently commissioned by experts. He's a frequently commissioned expert by public agencies in Sweden and abroad, and a source and participant in media reporting and debates. So we are in for a very interesting time. So Professor Munte, if you are ready, I will stop sharing my screen so that we go on to your talk, which is on managing complex value conflicts in public health policy, especially in view of tensions between health aims, political aims, and public acceptance or legitimacy.
So there you are. Can everybody hear me?
Yes.
Thank you so much for having invited me here. And besides all the things that were mentioned, I can also mention that I'm active, especially in some areas of particular interest. I've been active here in Europe in a competence network around COVID-19 pandemic regarding value issues and ethical issues. Especially here in Germany, but also in Austria and Switzerland. But I also have a general interest with this type of general public health challenges, for instance, the challenge of antibiotic resistance you might be familiar with. So I shortened the title a little bit, it's already a long title, and my talk is going to be pretty swift, and there's more information on the slides that I will mention verbally here, so you can look that up later. Well, so my starting point here is that the pandemic demonstrates a number of things that are of interest from a policymaking perspective. And one thing that's been very obvious to me is that there's a tremendous difficulty for policymakers and also for debaters in this area, people in general, to hold many thoughts at once. And I think this is the result of standing in front of what you perceive to be a frightening threat. So it's difficult to evaluate both the severity and nature of the public health threat that you're facing, but also both the benefits and the risks and costs of the different kind of policy responses that are contemplated in response to the threat. And there's a need coming out of this to consider a multitude of partly conflicting ways to evaluate health outcomes in particular, but also other kinds of values in general that we usually care about in private life or in society, and that are all recognized in one way or the other by ethical theories. And there's a very complex interconnectedness between all of these values, instrumentally but also pragmatically, and I will come back to that. So, so one thing is then to evaluate the severity of the threat as such and to evaluate policy responses. So often there's a simplification going on in reactions to this, that when you're facing a harsh threat, you think that any kind of response is a good response, but that's not so easy, unfortunately. So really the severity of the threat really says nothing about the value of a suggested response, even though psychologically it might feel like that. So a proposed response may actually make things even worse, or it might not have so much effect, so it wastes limited resources and capacities, or it may bring a number of unjustified side effects that we didn't think of. So just because we're facing an imminent threat doesn't mean we don't have to think through what we do in response to it. And now, psychologically, this becomes complicated in these sort of large-scale policy-making scenarios like the COVID-19 one, because when you do policy, you have certain suggestions that might make us feel safer, but they do not necessarily make us safer. So what make us feel safe is not necessarily what is best or most effective in actually combating the threat. And that makes policy making complicated, because policy is of course very dependent on how people feel about the policy. And in addition, then this policy making has to be done without evidence to a large extent. So there's a lot of severe uncertainty about all of these things, the severity of the threat, but also the consequences of different actions that you contemplate. But the fact, and sometimes the lack of evidence is used as an argument for doing just almost anything, but that's not so easy, because of course what you do might make the threat even worse than if you hadn't done that thing. And there's a large room in this landscape for actually reasonable disagreements, so people may evaluate from different perspectives and come to different conclusions in a very reasonable way, without being idiots or irrational or anything. But in spite of that, there's often a high effect in public debates regarding this area. So I will mention one complexity here. So already when we start to discuss how we should evaluate the health outcomes of the threat itself, for example a pandemic, or of the policies that we contemplate in response to it, it becomes complicated. So what should we be looking at? Should we be looking at only one thing? Should we look at how length of life is affected? Should we also look at quality of life as level of function for human beings? Or should we look at other things in society, more like public health kind of values, for instance? all of these parameters may easily pull in opposite directions. So an action that improves length of life may actually make the quality of life worse, or destroy the function in various ways, or the other way around. So that can already there be quite complicated. But only if we look at length of life, which has been like a very main concentration for a lot of people in evaluating things in the COVID-19 case, already there we must ask ourselves, okay, so what about length of life should we care about? So one way is, for example, is to count the number of people that die due to the disease, or the number of people who don't die due to different actions that we take. So that's one way of doing it. Another way of doing it is instead to look at the amount of loss of life that you lose, depending on who dies and so on. And also with action then, the amount of life that you save. So it might be that you have, and then it might be very different actions that are justified depending on, for example, how much life is lost when someone dies, for instance, because of a disease. That depends on the prognosis for that particular person, or the life expectancy for that particular person. And as we know, life expectancy and things like that can vary over groups, for instance. So what should we count? So in many cases when we evaluate health policies, we actually count not how many people die, but rather how much life that is lost. And then, for example, a person with very little life left that dies is counted as less of a loss than if a person with a lot of life left dies, for instance. So that can make a huge difference. And we can have disagreement, of course. And how should we balance the loss in all of these dimensions per person in the individual case against the number of persons that are affected? This may also be a variation depending on what policies we are thinking about. Yes, as I mentioned, most evaluations of medical procedures and clinical conditions and public health interventions actually take in all of these factors and try to balance them in various ways. But in the COVID-19 sort of policy situation, things have become very, very simplified often, and people look at only one thing. For example, how many people who die during a particular period or something like that. And another aspect is that during the COVID-19 there's been a lot of concentration on the possible positive effects of different kinds of actions, but very little concentration on the negative health effects of suggested policy responses. So one thing that has been listed is of course, for example, the domestic violence increase in Europe due to different kind of stay-at-home recommendations in different states. This is an observation in many states in Europe. But there are also other values than health. So one value that we usually cherish is the value of being able to control our own life and live it according to our own standards, to determine our own life, to be free and enjoy liberty in relation to other people and the state, for instance. A further value in societies, and this is often constrained, of course, by different kinds of policies. Equal treatment, equality before the law, or to have your interest equally considered compared to other people when you evaluate the policies, for instance. And often the policies in public health crisis will not treat people equally. We know that they will, the cost, the burdens and the benefits of the policy will often be unequally distributed. And that leads to the next question. So how much should we care about unequal distribution, and how much should we care about, for example, that the benefits may go to people who are already well off while the costs are carried, for example, mainly by people who are already worse off. This is often what happens in crisis management. Should we care about other aspects here? Economic impacts has been debated quite a lot, so how much should we take that into account? And something that in reality often comes to play a huge role are purely political values. So governments are worried about social cohesion, political legitimacy, democratic representation, national independence, social stability, these kinds of things that are really nothing to do with health or the good life of an individual, but rather things that on a national political level you care about when you try to make your policy. And it seems that this has a huge influence also on the actual policy making. So one thing to observe here is what we sometimes in public health ethics talk about as the double jeopardy paradox, and that's the thing then that I already hinted at, that the groups that are most at risk to be harmed by a public health crisis such as a pandemic are often also the group that are most at risk of being harmed by policy responses to this pandemic and this crisis. And they are the least empowered to voice claims against this or to protect their interest against authorities, for instance. So the policies that are then justified to protect against harm are actually harming the ones who are already the most vulnerable in this situation. This is a very common situation, and that complicates policy making quite a bit, I think, but that are very seldom voiced in the policy making rationale. So we come now to this connectedness, the complex interconnectedness. So of course many of these values will impact on each other. So for example, how the economy is affected by some policy may of course impact so what resources and capacity base you have for different kind of public health actions or healthcare, for instance. And also, but not only in this way, you also want to value different values differently depending on how other values look like at the moment. So for instance, if we stand in front of a more serious threat, we often value some things like freedom less, for instance. When the threat goes away, then we want to have our freedom back, but we are okay with having more restriction of freedom when some other life and limb is at risk, for instance. But there will still be fundamental disagreements, and they will not just go away just because policymakers then opt for some kind of policy, because they will always do that. And then, of course, one further aspect is that people will not adhere to the policy or not like the policy or protest against it. So we see actually quite a bit of this across Europe at the moment. And that may then seriously undermine actually the justification of the policy, because the policy is not as effective as it looked like when you had it on the drawing board in your policy making office. But in real life, people don't comply so much as you thought they would, for example. And this is partly because people may not agree with the way that policymakers actually make up the sums when they balance competing values against each other, but also that people respond to other values than health-related ones. So people are, of course, sensitive to health-related arguments, but they are also responding maybe more to other things. So someone turned off this. So someone need to mute the mic. I can't hear anything now. Thank you. So people might respond more to feelings about that the authorities are doing something. At least they are doing something. So that's better than if you proceed them to do nothing. So you want the government to look strong in a time of crisis. So that might be more important for how people respond to a policy than actually the effect of the policy on the problem. So there's a social psychology here that we also need to take into consideration when evaluating what works and what doesn't work. And when you do that, you might face a kind of a policy paradox that you actually, it might in reality be better to opt for a policy that on the drawing board in theory looks less effective on the particular target that you're thinking about, in this case, health, because if you don't take down your ambition here, people won't like the policy and you will actually have less of an overall good effect as a result. So this is a kind of huge complexity that makes it very, very difficult actually to evaluate policies in this area. Right, so we were also asked then the presenters to put some thoughts in your head for the discussion before, and I did this by formulating two different general questions. So one question is about, okay, so when you are in a health crisis, a public health crisis like this, so how much should policy be guided by other considerations than health? So all of these other things that I mentioned. So one thing, because I think this is a discussion that it's all often sort of hidden or not taken up. So there's so much focus on the health target that we don't discuss the other things. The other question is then, regarding the health target, what more exact aspects of health are the most important one to focus on? So for example here, these various way of caring about how length of life is affected, for instance. Should we look at, should we count deaths? Should we count how much life is lost? Should we count how many people die, or rather how much life is lost per person, or what should we look at? So these are just to put some thoughts in your head for the later discussion. So thank you.
Thank you very much. I think you have given us enough food for thought, because in all these discussions, especially during this pandemic, I think the primary focus has been on counting. You know, I am based in Accra here, and every day the numbers that we get are more with the number of people who have been infected, number tested, number who have died. But we sort of gloss over the other aspects, because I guess because many of those are sort of intangibles, we can't actually measure them. But you have given us enough information to think through many of these. So if there are any burning questions, we will take them now, and then we will move on to our next speaker before at the end of it all we have a general discussion. So if you can indicate with the show of hand if there's any question that you want to ask now. I have seen one in the chat. So Kathy is asking, how does the length or duration of a threat affect policy response? What are the main stresses impacting political decisions in terms of longevity of the threats?
So maybe that's more of a big question. I think this is a really good question, but maybe we should leave it for after, because not so much a technical question or a clarification.
All right. So I think then we will move on. Let me. So our next speaker is just a minute, is Dr. Katharina Kreppel. She's an adjunct professor at the Nelson Mandela African Institution of Science and Technology in Tanzania. She's a vector ecologist, epidemiologist, and a training coordinator for the African Aspire program, which is a Pan-African program building capacity in One Health research on the African continent. And her research interests lie in understanding the effects of a changing climate on vector-borne diseases and zoonosis to further the development of adaptive One Health strategies. She also works in close collaboration with the Fakara Health Institute in Tanzania and the University of Glasgow in UK. So Kathy, welcome, and you can share your screen.
Yes, I share my screen. I hope you can see it now.
We can.
Okay, good. So thank you very much, everybody, for joining us here today. I want to talk about the implications of COVID from a One Health approach perspective. And I'm based here in Africa, so you will find a little bit of a focus towards what is going on here on the African continent at the moment. When it comes to the One Health approach, and especially the One Health approach in the context of the current pandemic, we can see that we have 8 main areas that that came up as being some of the most important areas that the COVID pandemic has affected. They are not the only areas, of course, but there are some of those that we saw, those that work with One Health, as the most affected. So the first one of that would be the zoonotic diseases, of course. Antibiotic resistance, we also see an effect on food safety and food security, especially in low and middle income countries, and vector-borne diseases in the countries where we have those, environmental health all over the globe, and chronic diseases, mental health, and occupational health also all over the globe. So how does that all fit into the COVID-19 context? When it comes to zoonotic diseases, the main thing I would like to talk about today is the awareness that this pandemic brought towards zoonotic diseases, and also the reaction that was given when it came to becoming aware of these threats. When it comes to antibiotic resistance, I will go into the problem of co-infections. For food safety and food security, we all figured out by now that resources are finite, and for some people that was more of a news flash than for others. When it comes to vector-borne diseases, then I will talk a little bit about what effect the COVID pandemic had on the interventions against malaria and dengue. When it comes to environmental health, I would like to introduce you to the dilution effect, and of course other things such as air pollution, noise pollution, and all the other things that we became aware of more and more during this COVID-19 pandemic. For chronic diseases, I changed it a little bit. I don't think chronic diseases is quite accurate. I think there's the importance of non-communicable diseases that also includes chronic diseases. And then the importance of mental health and occupational health at the end. So what did we learn about zoonotic infections in the context of COVID? All over the world, people have now become aware, because of media and because of news and discussions, that COVID-19, that the coronavirus itself originated from an animal source. Those people that do not agree with that still have been told that this is one of the main theories. Therefore, people have now realized that animals in general can harbor diseases that can infect humans. And we can see that in the main scientific publications where scientists found SARS-CoV-2 related coronaviruses in pangolins, for example, as well as coronaviruses in bats. And we've all known in Europe the sudden revelation that we have large animal farms that can also harbor diseases, in this case, the actual coronavirus. And people were for the first time made aware, scientists were for the first time listened to, that were previously actually working on the margins. Suddenly it became very clear to everybody that animals pose a threat to human health. So what were the reactions towards this big drive of awareness towards zoonotic diseases? The main reactions all over the world were denial, avoidance, but also blame. And some advantageous reactions were a further aspect of collaboration, realizing the importance of collaboration, and also One Health platforms. And here we can see a wet market from Asia. And here on the right, we can see a schematic that represents the important collaboration, especially when it comes to a One Health approach. When we come to denial, then we come also to the conspiracy theories. And we had just this year in January, in quite a big journal in America, again, an article of the lab leak hypothesis, where people insist on the fact that the virus was probably created and leaked out of a laboratory in Asia. And in the continent that I'm sitting on in Africa, we have far stronger reactions. So of course we get the news and the media outlets here on the origin of the coronavirus. However, the reaction here is sometimes very different. The reactions here range from absolute denial to blaming other nations, to blaming the Americans, to want to reduce the population, to blame the Chinese trying to sell their medical equipments, their pharmaceutical things. And then we also have reactions that go into self-medicating or peddling medicinal cures such as bleach, drinking bleach. In India, we had a cure that was drinking cow urine, for example, having certain mixtures. There was some countries that were actually producing particular remedies. So we had a lot of these reactions, especially in Africa, where we have a lot of social media and very high network coverage, but not as much, not as high a level of education. The social media had a very, very strong impact on the reactions that people had to the coronavirus pandemic, and also in order to cope with the threat and cope with the fear for their lives, basically. And of course, in Europe, it wasn't very different. In Europe, we also had the big conspiracy theory that it is not the coronavirus, that the coronavirus is not caused by any virus from an animal or through transmission by people, that it is actually caused by 5G, so a stronger internet link. So when we come to the second part of antimicrobial resistance, then the question is, how is antimicrobial resistance linked to a virus, a viral disease? And here we see that what the first thing was, because there was no straightforward treatment for this new virus, that doctors, health practitioners, professionals, but also individuals started using antibacterials, antimicrobials. So antibiotics were prescribed as soon as people presented with coronavirus symptoms to a hospital. And at the beginning, particularly, so this article that I have here is from May last year, was that the scientists were actually promoting the prescription of antimicrobials simply because we found a link between comorbidities or co-infection and the severity of the disease. But very quickly, it became clear that the overuse of antimicrobials is a real threat to human health in the future. And here we see from a Lancet publication on this graph, the trends. So on the right-hand side, we have dexamethasone, that is a steroid, and it shows you here how often people Googled it, how often or when publications started to appear, when the WHO was reporting about that particular drug, what the Twitter trends were, and also the preprints that followed. So we have dexamethasone, as I said, that's a steroid, and then we have 3 antivirals, remdesivir, lopinavir, and the third one there, ritonavir. And we also have an antibiotic, azithromycin, and an antiparasitic, hydroxychloroquine. So all these medications were freely prescribed all over the world to a very huge amount of people. And individuals, especially in low and middle income countries, were also able to just walk down to their local pharmacy and actually buy these medications and self-medicate without any doctor regulating the treatment. And now my screen is stuck. Very sorry for that. And another thing that most people are not aware of is that it's not just the antibiotics and the antiparasitics that are being taken that you buy at a pharmacy or that you are prescribed at hospitals. But what is also driving antimicrobial resistance is the high concentration and high dose of disinfectants. And because we all use disinfectants far more regularly now and at a far bigger scale, we are already pre-selecting microbes that are more resistant, that are stronger, and can then later develop antibiotic resistance. Now, how does that link to One Health? The problem with antimicrobial resistance is that we are using antimicrobials in very, very large amounts all over the world for animals, for example. And when we have resistance, then the threat of other zoonotic diseases coming to humans and the other way around, from humans to animals, increases exponentially. Now, another point that I wanted to go to, and that links in with the antimicrobial resistance, because antimicrobial resistance is very much in humans, it's very much linked to the use of antimicrobials in animals and in livestock and food production. So we have food safety and food security. And here on the left, you can see the two pictures that I chose to explain the food safety. At the beginning of the pandemic, it was certain to everybody that we don't have to worry about food safety, that the virus cannot be transmitted through contaminated food. However, that changed, that information changed, and now we know that foods can carry the virus and that you can transmit the virus through food items. So therefore, in Europe, in America, we had very strong new advice on food safety, while in other countries and on other continents, this advice was not really out there. This advice was not published. It was just the usual, you should wash your food and you should cook your meat through, that we've been used to for a long while. So when it comes to food safety, we can clearly see that in low and middle income countries, there is a really big lack of information on food safety issues, mostly maybe also because there's not much that can be done. In low and middle income countries, there's a problem with accessing water to actually wash your foods, your vegetables and your fruits. And we also have a limited amount of fuel for cooking. So therefore, cooking your meat well also sometimes remains a challenge. And when it comes to food security, then we have quite a bad picture that most people are not aware of. COVID-19 actually dramatically increased acute food insecurity. And that means that the World Food Programme has estimated just in April this month that unfortunately we have 111 million more people at risk from acute food insecurity than we had last year. And on top of that, of course, that is partly the reason is that global food prices rose close to 20% in the last year. Now, this can't all be linked to the COVID pandemic. A lot has also to do with climate change, with bad weather events, also with conflict, and therefore the ability of a country to produce food. However, there is a clear link between the COVID-19 pandemic and the worsening of the situation when it comes to food security. And in particular, when we are looking at Africa, we can see that we are having a serious problem with the food preparation and producing food here in all these countries, because the majority of farmers here are actually women. And women are the ones that we now know all over the world are most vulnerable of the effects of the COVID-19 pandemic. They have less access to quality seeds and fertilizers, good land, credit, technical advice, new technologies, and that's mainly in the low and middle income countries. However, they also have limited mobility and time due to other responsibilities or due to lockdown, simply because they're not allowed to travel or simply because they have to stay at home to take care of the elderly, the sick and the children, and can therefore not go about the normal food production. And food safety, in their case, is also jeopardized. Now, when we come to vector-borne diseases, when we talk about growing and producing food, we also have to think about the health of the person that actually does the production and the people that live with vector-borne diseases in a world that is also suffering from a pandemic. And the diseases I chose here are mosquito-borne diseases, malaria, Zika, dengue, as well as tick-borne diseases and flea-borne diseases such as plague, for example. And the problems we have with vector-borne diseases are basically twofold. The first one is that, unfortunately, coronavirus pandemic sparked a search for certain drugs that might help in curing or treating the disease. And one of the drugs that was allocated was the hydroxychloroquine, what is a malaria medication. However, a lot of malaria mosquitoes are already resistant to hydroxychloroquine and taking more of this and actually prescribing more of this. And a lot of low and middle income countries have been giving out the information that taking that medication is useful for treating coronavirus disease, meant that we have seen an increase in the resistance of the malaria parasite, not the mosquito, the malaria parasite to this medication. And the main malaria medication we have at the moment in all the useful antimalarials that are in use globally is artemisinin. But that has already shown partial resistance. The parasites have developed partial resistance to it. But unfortunately, artemisinin is in the homemade remedy that Madagascar, for example, has been creating and has been selling to other countries. So scientists are not clear yet if that will cause more resistance and therefore increase the health problems we will get from vector-borne diseases. However, what is clear is that the pandemic brought a lot of misinformation. Because of the threat and the fear of the COVID-19 pandemic, a lot of misinformation was circulating or is circulating on social media. And for example, in Africa, in Sierra Leone, there was a big rumor that long-lasting insecticidal nets that are essential for preventing vector-borne diseases actually transmits COVID. Also, now that we have vaccinations, that vaccinations are there to reduce population, that they make you infertile, that they change your DNA, that they're used to insert a tracker into you, or that they make you sick. And the problem with that is that, unfortunately, this misinformation was not just about the coronavirus vaccine. This misinformation also spilled over to all vaccines, and that includes animal vaccinations as well as human vaccinations. And here we have the link to One Health again. Unfortunately, that means that we have less vaccinated animals, less vaccinated children, and we have also an effect on health-seeking behavior. So when it comes to vector-borne diseases, when you now get symptoms of malaria or any other vector-borne disease, very often people have changed their health-seeking behavior. They do not trust the normal medications and their health system as they did before. As well as reporting and surveillance has very much suffered during the pandemic, mainly because of a cut of resources, but also cut in travel. If you do surveillance, you do need to travel. And also a massive cut in interventions. Interventions such as vaccination campaigns, bed net distributions, malaria vaccine trials, for example, have all been severely impacted by the COVID pandemic. So when it comes to environmental health, then we know now that over the past few decades, more than 60% of emerging infectious diseases actually originated from wildlife or livestock. And what we also have seen now, and what has been dragged into the spotlight during the COVID-19 pandemic, was that how important environmental health is and how it affects the actual health of humans and animals. The main message that we got from the news, especially in Europe, was that biodiversity loss and ecosystem degradation reduces the habitats of animals and therefore increases contact with humans. And it also means that we have the biodiversity loss. A lot of animals are endangered or have reduced in numbers severely, what means that competition favors more resilient animals and also pushes them to travel and change habitat. And that's exactly what a problem is when it comes to environmental health and overspill and then causing bad human health effects. So the COVID-19 pandemic highlighted the interrelations between our natural and societal systems, and that societal resilience depends on a resilient environmental support system. Now, this was a little bit further away in Europe or America. However, it was very, very clear here and very, very well recognized here in Africa, where people are usually closer to nature. And unfortunately, often it relates to social inequalities. So environmental factors such as air quality appear to influence COVID-19 outcomes. And we've seen that with an increase in the severity and the outcome, worse outcome in COVID infections in areas where we have very high air pollution. And it also showed that the reliance on single-use plastic and low oil prices that results from lockdowns has negative consequences. If curfew and lockdowns has caused also in many African cities a trend to use single-use plastic, to not be able to go out and get your water, to be more likely to buy water bottles, to be more likely to use plastics. And we all know that in European and Northern American cities and Australia and other developed areas, we have started consuming even more, not less, when it comes to things like consumer goods, like clothes and other goods. And we're talking about internet, electricity, and all of these things. So while lockdowns during the COVID-19 pandemic may have some direct short-term positive effects, for example, now that we had reduced travel for a year, we can see a decrease in air pollution, a decrease in noise pollution in the seas as well as on land. Unfortunately, these things seem to be temporary, and especially where lockdowns open again, people seem to make up for what they have lost before. And how does that relate to non-communicable diseases? We know that comorbidities are a risk factor for severe COVID, and we know that chronic conditions, for example, need continuous treatment. The problem with that is that strained health systems cannot cope. And especially here in Africa, the systems couldn't cope before the pandemic, and they're struggling very much now during the pandemic. And the non-communicable diseases are also very directly impacted by environmental impacts, travel restriction, and of course, reduced interventions. People do not get their treatment anymore. They cannot access their medication that they should be taking continuously. A big problem is also cancer treatment, and a strained health system, hospitals simply cannot treat their chronic disease patients anymore. And here we come straight to mental health. Simply because, of course, if you have a non-communicable disease or if you're suffering with COVID yourself and you have unreliable health systems or unavailable health systems, then that directly goes to your mental health. But everybody else who is not suffering from COVID or is not suffering from another disease also struggles with mental health. Now here, it was already mentioned by the speaker before, by Christian, that we have seen an increase in domestic abuse. And we have seen that a lot here in Africa as well. Lockdowns seem to make that worse. Curfews certainly make that worse. But other mental health issues are also separated families because of restricted travel. Existential crises. This is something that is a very strong reality here. That is combined with housework, with job loss, on top of having to care for vulnerable people, grief, sickness, and livestock loss. These are just examples what we have here in Africa. However, in Europe, we also what is not just in Europe, it's probably globally, but you can hear a lot and you can see a lot of research now showing the problems of digital overload, of loneliness, especially the elderly, of the problem of having a single child at home that now cannot mix with peers anymore. And a big problem that we see is that people are not investing in the future anymore. They see the COVID-19 pandemic as a big threat. They're struggling. They have poor mental health. Many things, especially in Africa, are totally undiagnosed. People do not get help. There's no support system. And that very often means that investing in the future is not an issue anymore. People do not invest in the future, what means that we will see the outcome and the results of that in the years to come. And COVID-19 places extra mental health risks on women. COVID-19 has intensified gender inequality everywhere around the globe. Many women have to work harder while earning even less. Jobs are usually cut. Jobs that are cut are very often informal jobs that are done by women. Girls have been taken out of school as a result of less income and because they are needed to help at home with the chores. And that is not linked to school closures. It is simply that when there's job loss and there's financial problems, that girls are usually the first ones to be taken out of school. And also the problem with women and the way they live in many low and middle income countries means that it's very, very hard for them to actually avoid infection. And that puts a very, very big mental health stress on them. And lastly, I would like to go into occupational health, the exposure to pathogens, exposure to pathogens by healthcare personnel and by essential workers as well. And it's not just the exposure to COVID-19. Occupational health includes physical and mental health. And we can see this as a big problem when it comes to essential workers, just as people that are doing waste removal, people that are running buses, for example, bus drivers, any essential workers that you even have in supermarkets, people that you don't actually realize are suffering under the COVID pandemic directly without being, most people just think of nurses and doctors as the healthcare personnel that is really being exposed to pathogens. We are forgetting very often about the essential workers that are also around. And this also includes farmers, subsistence farmers and livestock keepers. Occupational health is at risk for them. I've said before, it all links together. Livestock keepers, for example, are at higher risk of contracting zoonotic diseases simply because either vaccination interventions are not running anymore, or they decided against vaccinating their animals due to rumors or any other conspiracy theories, and therefore putting themselves at risk of other zoonotic diseases. Then occupational health is also linked to traveling in crowded conditions, what is a reality for many around the globe. One very direct link is preparing bushmeat during the COVID-19 pandemic. We've said before, the food insecurity has increased, what also means that the consumption of bushmeat has increased, and that is a recipe for getting a new pathogen. Then we have lack of information. We have previously affected health. As I said before, we have chronic conditions, we have non-communicable diseases. And of course, especially in low and middle income countries, we have dire lack of protective clothing, not just against COVID, but against any zoonotic diseases. And this is all made worse during the COVID-19 pandemic, simply because of lack of resources. So finally, I arrived at the slide to ask you, what can we do? What can we do to improve the situation when it comes to One Health issues or issues with the One Health approach during the COVID-19 pandemic? We know that a multitude of problems have been enhanced by the pandemic. However, I see it as a chance to tackle these issues. We have learned a lot. People on the street are far more aware of certain problems. And I think the priority is to protect our most vulnerable members of society and hope to give them a voice. As the speaker before me has said, there is this double jeopardy paradox. That means that the most vulnerable very often do not have a voice. And I think this is the main issue we should think about and try to give those that are most vulnerable a voice and find ways to listen and find ways to get better information out there on all these issues that I've just covered. Thank you very much.
Thank you so much, Kathy, for that. I think we have a lot to discuss, but I will begin with one question in the chat from Sarah Mora of Costa Rica. So she's saying in her country, numbers are growing very fast, and it seems the numbers are growing fast, and it seems that their health system would not be able to face it. And the government is probably unable to close or limit movement due to economic crisis. So in this context, she's asking,
yes, what I can see it in the chat.
Okay.
So she was asking, what effective measures do I recommend to help lower pandemic numbers without risking the economy? Now, I live in a country where this was the exact reaction of the government here. They decided very early they cannot risk a lockdown. The economy is too unstable to deal with a lockdown. However, here we then had a problem that all information was cut off from the government. We were not informed of any cases, and nothing was put out there to tell the people how to protect themselves. So what I would recommend, if a lockdown is not possible, and we can see very often that there are things in place, like we've heard before, like curfews, for example. In our neighboring country, Kenya, we have curfews every night. And the question is, the government looks like they're doing something, but how efficient are they really? Now, when you ask me for a recommendation, it's very, very hard to come up with a recommendation. But here in Tanzania, where we had no measures whatsoever, I would have wanted more information from the government to enable those people that can protect themselves to protect themselves. So, for example, making it absolutely mandatory if you enter a public building or a bank or a supermarket or any enclosed space to wear a mask. Also that you have to have hand washing stations outside every shop. This was something that was encouraged at the beginning here in Tanzania in the pandemic, but then after coronavirus was declared to not exist in this country anymore, that was totally unenforced. And I would say my recommendation is give the population as much information as possible without having any fear mongering. Protect your health professionals as much as you can with protective equipment, and make sure you have social distancing rules and mask wearing in any indoor environments. So there are a lot of measures you can do without locking down the community. You can limit the amount of people that are allowed on a bus to make them less crowded. You can make sure everybody has hand washing stations. You can make sure there's enough soap and protective equipment available. You can make sure that the number of visitors to sick people is limited. In Africa, very often whole families of 15 people come to visit the sick person in hospital. And that, of course, is a big spreading event if there's coronavirus. So these are my recommendations. There is a middle ground we can do. The problem is always that the government say that if you take these measures, people get scared and you get a panic. So this is something to weigh up. But I think there are lots of small things you can do, and especially giving information out to enable those that can protect themselves to actually protect themselves.
So may I add something? I totally agree with you with all of those things. And I come from a country then that has not locked down. I mean, it's been Sweden is a bit famous for this. So basically, most of the policies are based on recommendations given to people, and some actions taken by public agencies and things like that. But it's only now during when we see the vaccine coming that the policies have become tougher because we see the end in that sense. So, but before that we didn't know. So this connects actually to Kathy's question during my talk. So, how should you think about the longevity of the situation and how to sort of factor that into the policy? And actually, so if you have like an unlimited time period before you, you can't see an end. That's very different. Then whatever you do, it must be sustainable for a long time, and it must be not only technically and economically sustainable, it must be politically and socially sustainable. So you need to secure that you're not being too hard, because then you get the population against you, and then it's even worse actually than if you do nothing probably. So that's one aspect. But a lot of these simple things that maybe you would recommend, even for example to limit antibiotic resistance even without the pandemic, that you maybe we should wash our hands a little bit more and be a little bit better at avoiding other people physically when we feel we have some symptoms in our nose or mouth or things like that. So there's sort of simple things, and just nag about that and have a lot of information. And in Europe, there's been a lot of information campaigns like this, and sometimes combined with the policy built on recommendations, as in the Swedish case a lot. But I also spent quite a bit of time in Germany, where there has been more compulsory regulation, and a little bit of curfew is coming now in Berlin and things like that, and a lot of closing of shops and things like that. So but then you can still, even if you do those things, I think if you cannot mobilize sort of the voluntary actions of ordinary people, you will have much less effect. So I think the voluntary actions of ordinary people, and actually try to build some kind of culture of confidence from the government towards the people, so that the people see, okay, so they trust us actually to take care of this, in order not then to lock down and totally destroy the economy and the businesses and all of that thing. And I can say that the economic situation is, I mean, so European states are rich, so they can take a lot of state credits and hand out money in order to help businesses survive and things like that. But afterwards, there will of course be a bill to manage, and this bill will be managed for probably several decades. So also in a rich country context where I come from and live, there will be these things that will probably echo for quite some time in the political aftermath of all this. So it can't, of course, be combined to a country like Costa Rica, where the capacity sort of level is totally different. But you will always have these trade-offs, I think, also when you have the rich countries.
Okay, thank you very much. Do we have any questions from our participants? Let me check if there's any hand up.
Yeah.
No? Okay, then maybe I will take your take on this, Christian. So we are all well aware of what's happening in India at the moment. There are suggestions that maybe they lifted their lockdown too soon. It gave people the impression that everything was okay and people lowered their guards. And now there's a lot of panic, and questions are being asked as to exactly what went wrong. So based on what you shared with us today, how do we balance this dilemma between saving people through interventions like lockdown versus loss of livelihood due to job loss due to the lockdown? And how do we just address this complexity of public health policy considering the poor? We know the dynamics of India. And today I read that many people are actually now scared to come out of their house. There's no lockdown, But with what is going on, many people are actually scared and they are imposing their own lockdown on themselves. So what's your take on the situation now, and what will be the best strategy for them going forward?
So I think, so when I think about this and I see all of these debates, you know, in many countries, we have these debates in Sweden, we have them in Germany, we have them all over the place, and in India, of course. I mean, so one of the most difficult things about this is that we don't know the effects of the policies. We are guessing and we are hoping that various types of, so when we say, so maybe it's because we lifted the lockdown too early, or you kept it too long. Maybe it's some kind of effect we don't know about, that some behavioral effect of people that we don't know about. So we know nothing about this. And I think the first step is to be open about that. I think one of the big policy problems in the whole world is that political leaders and health experts are trying to project a level of certainty that's not there. So I think that's one of the main problems. And so then you tell people, oh, we're going to do this and this, and this is going to help a lot. And then it doesn't really materialize in the way that you hoped for. And in some other country, maybe the other country, so we're in the situation, so we have a very different kind of numbers for everything. And then we compare ourselves to Finland, which is very, very close. It's one of our main neighbors, and they have very different situations, but their policy has not been so different from ours, actually. And then you understand that there's a lot of factors here that nobody is really controlling, and that seem to be affecting how the pandemic then develops. So that's one aspect. Another aspect, I think, is that there is this way of talking that you say that, okay, so people and businesses are now closing down because of the pandemic. But they are not closing down because of the pandemic. They're closing down because of the political response to the pandemic. And actually be open about that also, that there are the effects of the disease, and for sure, if we would do nothing about the disease and do nothing about picking up the consequences of disease, that would have a tremendous economic impact as well. But the policy measures also have these other impacts that impact people. So I think one of the problematic things to have, like, sort of interesting and well-ordered discussions about this is that you acknowledge the level of difficulty and complexity of the problems to start with. And that contains the uncertainty and the fact that it's not only the threat that you're facing that do harm, it's also the response to the threat that do harm, so that you actually have that on the table to start with. And I mean, so I come from a country where the policy has been fairly moderated, but also here the government and the responsible agencies have had a huge difficulty being open about this. And I think this leads to backlash in public debates and in legitimacy and in public acceptance of policies. And this, especially this thing that was mentioned in the chat about the general public's perseverance when the time drags out, because I think that's essential, actually. So if you don't get it, doesn't matter how many policies you have and how many advices you give and so on and so forth. If people don't keep on, okay, so we keep on doing our part and hope for the best, then you won't get any of the effects that you hope for anyway, really. But so openness about this complexity is my first thing then.
I also have two points to add to that. First of all, this is not the first and last pandemic. That's something very important. Like I said, my whole talk was about the effects of COVID on the One Health approach. And we can see that we are sitting on a time bomb here. Epidemiologists have predicted this pandemic decades ago. We were just waiting for an outbreak like this to happen. And the truth is that there will be other outbreaks like this. There will be other pandemics. And I understand the frustration that is building in every society. So that's my first point, that we really need to change. And for India, I think it's very important, first of all, in total, the population in India actually suffers from quite bad health. On average, they have a very high rate of non-communicable diseases. They have some of the world's highest rates of diabetes, for example. They have some of the highest rates of obesity and overweight. So that all makes them very, very, very vulnerable. And it includes young people as well. We see a lot of young people being sick and dying in India now, something we haven't seen so much before. And the question was always if that variant is now worse for young people. But one of the main things also to see is the health condition that people are in. And the health conditions over there are not very good. And that is also combined with massive air pollution, massive environmental pollution that we have over there. And what the other point I wanted to make, what links in what we have seen here in Tanzania, where the government totally stopped taking responsibility for anything. We have seen religious leaders stepping up. Religious leaders were stepping up, trying to lead and guide the populations because they were requested to do so. But unfortunately, without the government leadership and without the right information, many have been misguiding people. So there were full-packed mosques, full-packed churches, religious holidays were fuller than usual. That's the same in India right now. We have seen the pictures of massive crowds celebrating religious festivals together. And I think it's really, really important that the governments work together with their religious leaders, because this is not the last pandemic. And we have seen how important religious leaders and religion in general is in a time of threat, in a time of panic and fear. And therefore, we need to acknowledge that while we separate in many, many countries, in most countries, it's secular. So we have a separation between church and government, but that doesn't mean we shouldn't work together. And here in Tanzania, I've seen that once the churches and the religious leaders from also the Muslim communities have taken action and have told the people to mask, to social distance, to wash their hands, things have become better here. People have started to listen and taking information in. So I think that's another point. That's another thing we have to do, simply because coronavirus will not go away. We might be able to control it, but it will not go away. And the next pandemic is just around the corner. This is not a question. That's why I had my question about the duration, because this is not a situation that will go away. We will not go back to normal, unfortunately.
Wow, that's interesting. So I guess that will bring me to my next question then. What strategies should be prioritized internationally to prevent future pandemics, knowing that we all acknowledge that this certainly is not the last pandemic? What should we prioritize? Maybe when I come to you, Kat, maybe you can focus more on within the context of Africa.
Well, within the
yeah,
we just had a big blow because the UK, a major donor for research here in Africa, has just cut the funding substantially for many research projects that are running in Africa and in other low and middle income countries as well. So I would say the main thing, if there's only one thing to do, only one thing you concentrate on, it's surveillance. You really need to step up surveillance. And it's not about European people coming into Africa and looking for things. It's about building capacity in every country to look at their own environments, to look at their animals, their humans, and their environments. I think surveillance is the main part that we can all improve at, and we should have local surveillance. Like I said, we need capacity in every country to look for the right direction. If we have surveillance, we can avoid so many deaths, so many cases, and so much spread. So this is, and we've seen with the Ebola crisis how it can go wrong, how an intervention can go wrong, because it was based on the, as I call it, the old system of Europeans or Americans coming into a different environment and then just coming with their solutions and taking their samples in whatever way they want. And we've seen it's gone wrong. So hopefully in this pandemic, what we will learn is to increase surveillance and to increase surveillance capacity in every country in the world.
Totally agree, and only also add that so surveillance means several things here, right, Kathy? So first, the surveillance about the zoonotic possible development here of new, basically new human pathogens developing, and to catch them sort of in the early stages, but also then the kind of surveillance you use in the sort of first phase of communicable disease management, where you can, if you have a strong communicable disease, contact tracing and surveillance and testing organization. So this is actually, I think, the biggest lesson from some of those countries that really have managed well, is that they have, I mean, partly some of them have been lucky with not so much coming into the country, but I think Finland is a little bit like that. That's what they say themselves. But also because they have been one of the slowest countries in Europe to dismantle the old preparedness from the Cold War era. Because of the proximity to Russia, I think they have been partly very slow there. They had a lot of, old readiness that other countries didn't have, basically, because we had dismantled this during the happy 90s and early 2010s because we thought we were invulnerable, basically. And therefore they had they could avoid this sort of general community transmission situation, which is when things get out of hand in any country, basically, that your level of capacity to avoid the general community transmission situation is better. So, and I think this is also the lesson from South Korea, right? That because of the MERS that hit them very hard, they developed this capacity that almost no other country had. So you have this sort of interesting example to actually learn from. And I think the South Korean example is also interesting because it's not based on a situation of having an access to a lot of high level, professionals, like they use ordinary people to a large extent.
Yeah, we have something in Africa. There was also a wake up here. We do have One Health platforms now in many governments, what means that there is a contact between veterinarians and medical doctors and environmental experts. But what was noted was that they haven't been implemented. So they were there, they had been organized, they had been in place, but they haven't been implemented. But we've seen here that especially lessons learned from other diseases, such as Ebola, such as rabies, for example, made contact tracing much easier and much better. And before Tanzania didn't have any COVID cases anymore, they were actually very active in contact tracing. And that was all based on a contact tracing system that was developed for anthrax and rabies. So there is experience and there are structures in place, like you said, in the case of Finland. In Africa, there are structures all over the place that they just have to be implemented and they have to be funded. So I think, like you said, surveillance and contact tracing is a very, very important part of it.
So one of the things that are, this is also the story, I think, of these European countries that have, I think all across Europe there is a big surprise about the development. So all in Europe when this started were saying, well, it's going to go to hell in Asia and Africa, but we are going to make it because we have such resilient systems. Well, it doesn't look like that, right? And there's a lot of lessons to learn there, because there's the question of how you evaluate and how you value readiness and preparedness and resilience, because that's basically that you have something that you're not really using right now, but that you can use just in case. So it's a bit like buying an insurance, that you're paying your premium on your personal insurance in case someone breaks into your house or because, something like that. And you're paying really for nothing until something happens. And this is a bit, and I think this is often what happens, that it becomes politically difficult to justify and motivate taxpayers and to fund this readiness, because it just stands there and waits.
That's what happened in America, isn't it? They had a disaster preparedness team, and then it was defunded.
Yeah, and actually a lot, I mean, Sweden, which is sort of famous for having a really strong health system, also here, because in order to lower the taxes, they started to implement these things where you outsource everything to private contractors, and they are minimizing the running costs and everything, and it becomes politically popular for everybody to lower the tax level and then you're in a political situation where you can't really say that we need to pay more to build up this readiness. I think now there is, but before it wasn't. So I think
Yeah,
it's,
the only problem, I think, what is still a problem, I mean, the nations are donating to the COVAX system,
yeah,
but they're actually reducing the funding for the readiness of the low and middle income countries. And
yes,
that's something that people do not realize, because the
no,
normal people, they just see 200 million vaccine doses donated to COVAX, but they don't see that US has just reduced the funding, UK has
no.
just reduced the funding. And the problem with that is simply, like the WHO director said, we are not safe until all of us are safe.
No.
And that is a big problem, that these readiness should also be funded in poorer countries. Otherwise, you won't be ready.
Yes, totally agree.
So,
Okay, thank you very much. Interesting discussion. Any inputs from any of our participants? You can also put the comments in the chat, or if you want to ask a question or make a contribution, you can use the raise hand option. Let me see. I don't see any. So maybe we'll take some concluding comments, and I'll hand it over to my colleague Deepak to take us to the end. So any concluding comments from either of you?
Yes, so since we're already into the area of capacity, I think that's so capacity building and capacity maintenance. And I think one area that popped up, I think also a little bit surprisingly to us here in the global north and west and so on, was the lack of capacity, for example, for vaccine production. So we're totally dependent on few factories, and some of these factories are far away in other countries. So the whole pharmaceutical production system is very, very vulnerable. This is something we already worry about in the antibiotic resistance area. But it's also we see it very, very clearly, I think, regarding the vaccine production here. So and if you add that together with how the patent system and the sort of global trade systems prevent poor countries for setting up their own production where they just copy something and don't mind the patent. We just bring in someone to manufacture what we need, and but the problem is that you will be hit by these kind of trade repercussions if you do that at the moment. Um, but I think that something that will be an issue certainly in Europe will be that there will be discussion about strengthening European capacity to actually make our own drugs. Um, and not be so dependent on this sort of business model that the big pharma companies have, that's very, very vulnerable actually regarding things. So that can be put together with these other capacity points. I think capacity, I totally agree. So capacity and preparedness is the main key, and for the next pandemic, because I totally agree with Kathy that there will be another one.
can I just, as a closing remark, I have a question for Gloria.
Yeah.
Gloria, do you think that this pandemic has been a wake-up call for African countries to invest more in their surveillance and in their testing and contact tracing abilities?
Yes, I mean, I can speak of my experience working in a medical research facility in Accra. Prior to the pandemic, I can say many people were unaware that we were here doing research or what exactly we were doing. Of course, the government was aware, and when it started, I think we were the first institution that they called upon, and we were able to kickstart the testing because we actually had the capacity, the personnel, the facilities, and all that to do it. But of course, one institution doing that for the whole country, it became quite obvious that we could not cope with the load. But what happened subsequently was that a lot of non-governmental institutions, even individuals, just walked into the institution and wanted to know what we needed. Like all of a sudden, people were interested in research and in building enough capacity because they saw that if the institution was not there, then we would have been far worse off. And so for us, we see that to a certain extent, through this, capacity has been built because now the testing has been decentralized. A lot of labs have been set up, people have been trained. We have even roped in the veterinary labs, so sort of like a One Health approach, because there are some places where we did not have any hospital-based lab. So, but where there was a veterinary lab, they could also do that. And going forward, I think this year's budget, for instance, there was I've forgotten the exact percentage, but this was the first time that the government actually allocated enough funds for research and development. And for how we have handled it so far, I think just as you mentioned, we already had some of the structures set up. I think a lot of people were surprised at how many of the African countries handled this whole pandemic. Even with the vaccination for Ghana, Ghana was the first country to get this COVID vaccine. There was a lot of media engagement around it, and people were asking questions, how were we going to go about vaccinating this population? But forgetting that we have been vaccinating people from years back. So the structures, everything is there. Even in the very remote areas, we have mechanisms for going there to vaccinate because of this whole system of the childhood vaccination. So they just use that same setup. And within a matter of weeks, a lot of people who were supposed to get the vaccines had received the vaccine. Of course, now the issue is how we are going to get the second dose based on all that is happening in India and all that. So I think some countries were caught off guard, but many African countries were also able to meet the challenge despite the financial constraints. But I think the right lessons have been learned, and going forward, governments are going to devote more funds towards research and development. Of course, last week, the African Union met with the African CDC, and they have set up this whole facility of trying to go into vaccine development, because this whole population of Africa producing just 1% of the vaccines that we need is a problem. And they realize that obviously this cannot be a money-making venture, because people would just not have the funds to purchase these vaccines. So it has to be the government contributing together with the wealthy industries to set up this so that it can be given for free for the population. Of course, this will not be now, because the business of vaccine production is not a one-day wonder, but it was heartwarming to see that they had actually met to discuss something like that, and they are thinking hopefully in the next 20 years we should see some benefits. So despite the challenges, I think there's been a ray of sunshine in all this, and hopefully that should work for the betterment. I see that somebody wants to. Azad, I see your hand up. You were taking closing comments, but I guess you can still make your comment. Azad, you can unmute. Hello. Oh, was just Azad, I see your hand up. Okay. Then Kathy, maybe back to you, or you were done with your comment?
I was done. I just wanted to hear your opinion on this.
Okay. All right. So, Deepak.
Yeah, Ivy, thank you.
Yeah. Okay. You can take over from here.
Okay. So, yeah, on behalf of One Health Knowledge Café organizing team, I would like to really thank Christian and Kathy for your very thought-provoking ideas and presentation. And this has been really interesting talk. We all benefited. So on behalf of all the audience and the organizing team, would like to thank you. And as we all concluded, so this is not the last pandemic. we need to learn from this, and we need to invest more in health system, in research and development, in surveillance system, so that we can cope with any future pandemic of this kind. Or yeah, so that's the main lesson that we learned from this one. So thank you very much. I would also like to thank all participants who are here, who contributed. I would also like to thank Sabina for providing necessary backup support on this one. As we mentioned in the beginning, we have been doing this kind of webinars for a couple of months by now. Let me just share some of the upcoming events. So we have a plan to talk about vaccines and treatment for COVID-19 progress since 2020. So we also had one webinar in 2020 about vaccine development, and since then and now we have different choices, different progress that we have made. And if anyone of you is really interested to learn more about that, you can log in into that one. And in June, we have a plan to talk about epidemiology of COVID-19 and risk communication approaches. And we also talk about importance of disseminating information, communicating people, letting them decide what is good for them, good for their health. So we'd also be talking about those topics. There might be more that we might be organizing, but these are the upcoming webinars that we have in our plan. I'd like to thank again for your attendance, your contribution. And as we said in the beginning, PowerPoint slides and webinar recording will be available in our website, that is www.cis.lmu.de. So with this, I'd like to announce the closure of this webinar. Thank you very much.
Thank you very much.
Bye-bye, everyone.
At the next webinar.